Hello everyone, this is Dr. Dandekar. Our today's topic is urinary bladder calculi, that is also commonly called as Vesical calculus. This is our continuation of lecture in the lower genitourinary tract series. Objective of this session are to introduce pathophysiology, types, etiology, clinical features, investigation and management of bladder stone. The possible long question on this topic can be: describe the etiology, clinical features, investigations and management of vesical stone or bladder stone. There could be short notes on diagnosis of bladder stone, investigations for bladder stone. Actually this is a same question but the wording is different. Then you can write down a short note on cystolitholapaxy, either open cystolitholapaxy or endoscopic lithotomy. Then you can talk about litholapaxy and a note on management of either 1.5 cm, that is a small stone, or a 3 cm, that is a moderate size stone, or a very large stone which is more than 5 cm. In addition, you may write, or some old paper might show you this, a short note on triple phosphate bladder stone. Nowadays this is not asked because it goes into the either nice to know or a desirable to know content. So this is more of a, as it is written here, it's a uncommon in Western world, but it is very common in our area as well as in Asian as well as the African countries. Maybe there is a problem that is related with the protein energy malnutrition as well as some infection or parasitic infestations like cystosomiasis. Also the rate of infection is higher in Asian as well as African countries. This is a well-known medical problem and lots of information is available in ancient medical literature. So if you try to find out, then you will get very interesting anecdotes about the urinary bladder stone. Hippocrates has wrote about the management of the bladder stone in ancient. Then the operations to remove the stones via perineum were described in the centuries BC, before Christ. And obviously the fatal outcome of the procedures are also noted. Then the suprapubic lithotomy was described in the 15th century and first lithotripsy was attempted in 1822. I tried to find out the details of this lithotripsy, what they exactly wanted to state about the lithotripsy, but I was not able to find out details. So I leave it up to you to find out what is this information about the 1822 lithotripsy. And there is a very specific mention in the ancient literature that all the surgery or all the treatment associated with the urinary stone or rather bladder stone were associated with a significant morbidity as well as mortality. So it was a big question that how to deal with this urinary bladder. Now before going into the how they are formed or what is the pathophysiology of the bladder stone, let us first find out or let us have some orientation regarding the types of the stone. And remember, if you take a genitourinary tract, then the major source of formation of stone is in the kidney. The stones which are formed in the kidney are called as a primary stone. And most of them, they will come into the bladder and they will grow. So a fertile land for formation of the stone is actually kidney. But there are certain situations because the urinary bladder is a reservoir for the urine. So in some condition there is chances that there will be stasis. So if this stasis is increased and certain physical conditions are associated with that, so that theory we are going to learn about. So it's a physics, how the stone is formed or rather how the precipitation takes place. Then there is a crystallization of the solids. that will aggregate and that will form the stone. So, but here I want to I took this point in the earlier slides because first let us state them as a primary and secondary stones. So what are the primary stones? So the primary stones usually develop in kidney. Most of them originate in the kidney, grow in the urinary bladder. They will come down and then they will grow into the urinary bladder, and there is a possibility that they may develop into the sterile urine also. The primary stones are usually of oxalate or uric acid or urate type. So there will be the stones, the primary stones, if you want to list the names, it could be calcium oxalate stone, uric acid stones, urate stone or cystine stone. And it may happen that the first primary stones are composed of these four types, either calcium, uric acid, urate or cystine. Later they land up into the bladder stone and then they get covered secondarily with the phosphate material. So it could be a mixed stone or sometimes you might find. Now let us see the secondary vesical calculus. These are most of the time associated with the infection. Then mostly they originate in the bladder. So as I said, primary calculi will originate in the kidney, then they will travel into the bladder and they will grow. But here there are physical situations in which there will be a deposition of the crystals from the urine and that will form into the stones and that will happen into the bladder. The chemical composition of this secondary vesical calculus is usually called as a triple phosphate, and it is made up of either ammonium phosphate, calcium phosphate or the magnesium phosphate. So how these stones are formed? So usually this deposition happens. So there are the physical condition, one is the infection, another is stasis, and there is a presence of a crystalline material whose concentration has increased. So the solution out of this urinary solution, water is the solvent, the crystals are the solute. So there are situations where the concentration of solute is either increased or the amount of solvent, that is water, is decreased, and the third situation is that the flow of the urine or the staying period of the urine has increased because of the stasis. All these three will lead to the precipitation and deposition of the solid material, which will aggregate together to form a small stone. But why they are coming together? So they find a platform or foothold over the matrix or a nidus which is formed by the dead bacteria as well as desquamated cells. That is why infection plays a very important part, and that is how first a small stone is formed which later grows in the size. Just to give you a prior information that if there is a large stone and if you see an X-ray, you will notice that it is not a solid X-ray, but you can make out a concentric rings which start from the center and you can literally make out they are formed one upon another, forming a deposited stone. And that is the reason if you drop this stone from your hand and when it hits the ground, it gets fragmented. Why I am telling you this? Because these stones are not hard like a stone that you are observing in the nature or outside. If you try to break a stone which is lying outside, that will not break easily. But if you throw this stone which is coming from the bladder, that will easily disintegrate. And this property, why? Because it is made up of particles aggregated together. So it is fragile and gets fragmented easily. So this property you can use for a certain treatment like a ESW, that is a lithotripsy, or that is called as a extracorporeal shock wave lithotripsy, in which you can use a sound waves to fragment the stone. So one thing we have clearly seen that bladder calculi are associated usually with a urinary stasis, and urinary infection increases the risk of the stone formation. In addition to that, so we said stasis, urinary infection, these are the natural conditions. But there are certain additional conditions which will increase the formation of the stone. As I said, the stones are formed over a nidus. In infected and stagnant urine, that nidus or a platform is provided by the matrix of the dead bacteria. But sometimes it may happen that there are certain foreign bodies which are present. I am going to give you the whole list, but here just state some examples. Example, suture material. Suppose there is last time we saw that there was a bladder injury. Now you take a suture, and if the sutures are present, they will act as a foreign body. Or sometimes there are digestate which are left in the bladder. They will give a solid platform for the deposition, and this will be a very good environment for the formation of bladder stone. Now it means that every time there has to be infection? No. In some patient there can be a formation of a stone in the normal urinars. Now let us see the pathophysiology part of it. Already we have started it. So most of the bladder calculi are secondary. Majority of the bladder calculi are secondary, while only few will constitute a primary stone, and they will be coming from the kidney or from the upper urinary tract. They vary in size and can be multiple. So you will see a spectrum. Sometimes you will find that there are very small but multiple number of stones which are present in the bladder in the form of a sludge, or you can find there are very large single bladder stone which is occupying sometimes almost all of the bladder. It is present in the extreme spectrum. See, in India you will see that the bladder stones are very common in elderly patient, as well as you will also notice that small children below the age of 5 are also coming with a large stone. And in Asia this might be happening in the children because of protein energy malnutrition, or there are some chemical factors which are responsible. Here you will note that in Pravara Rural Hospital we have a pediatric wing, and almost every month we are operating at least 1 or 2 children below the age of 3 to 4 years for this bladder stone. Now if you see the statistics, that most of the stones in the adult are formed of uric acid, or I can tell you the original, the basic stone which is inside and later is grows into the secondary stone. So the nucleus is usually made up of a primary stone made up of a uric acid. There is one more additional thing, that if the stones are not treated for a long time, then the long-standing untreated bladder stones are associated with a squamous cell carcinoma. There is a simple reason: because of their spikes, because of their hard surface, because of their rough surface, they are constantly causing a minor trauma. If that stays for a long time, that will develop into the ulcer, and that will change the transitional epithelium to the squamous cell epithelium, and later, because of the continued trauma, it may get converted into malignancy of a squamous cell carcinoma. So let us see how they grow into the presence of foreign bodies. You will find that this is one of the very common reason, not the primary reason, but this is a common reason, that if there is a presence of foreign body in the bladder, that will lead to a formation of stone. So first, last time we have considered this, that's why you have to keep the knots outside. If you are repairing the injury of the bladder, if you are taking the suture, you make sure that the knots are buried, knots are not present inside the bladder, because that suture will help in stone formation. Now this is Foley catheter. This is so common, and let me tell you, don't take Foley catheter lightly. It may happen that patient come to you, usually they are elderly patient, They come for other conditions like paralysis, and the relatives take them home, and for 3 months, 4 months the catheter is not changed. Or sometimes it may happen the patient comes to you for the change of catheter, and then you try to remove the catheter, it becomes very difficult to remove the catheter. Why? Because that tip now has given that tip is covered with an encrustation, and it becomes very difficult to take it out. So always remember, while you are removing the Foley catheter after prolonged time, remember that it may have a encrustation because of the early stone formation. So removal of this Foley catheter must be very gentle, otherwise it will cause ulceration inside the bladder and throughout the urethra. You can see here a diagram. This is a Foley catheter which was left for a long time, and how it has to be removed? It is removed by operation. So the distal end is cut and is removed via suprapubic cystolitholapaxy by opening the bladder from above. Next possibility is forgotten stent. You are aware of DJ stent, that is a double J stent, which are kept from the kidney to the bladder to keep the ureter open. Usually it is kept when there are ureteric stone or there is obstructive uropathy. So in that case, in this way the DJ stent is kept. So one of the J end is in the pelvis and another J end is in the bladder. You are supposed to keep this DJ stent only up to the 2 weeks, 15 days, maximum 3 weeks, and you have to remove it. If it stays, then it is a nice platform for a stone formation. You can see here is a diagram. This is our patient which has presented with a bladder stone. Patient was operated somewhere some 15 years back at Mumbai, and a stent was kept. His discharge card has very specifically in a bold letter written that come for stent removal after 15 days. But for some reason the patient never reported to the hospital, and after 11 years this patient came with a bladder stone. Then pieces of drains which are forgotten in the bladder are known to cause. See, this is a piece, suprapubic catheter. Usually sometimes it happens that it may get broken, stays inside, and it develops into the urinary bladder stone. Then long-standing suprapubic catheter. Similarly, suprapubic catheter is introduced from above, but what you use is the Foley catheter or a plastic catheter which stays for a long time. And longer the catheter stays, more are the chances of formation of a. Now, what are the reasons that may lead to the bladder stone formation? First is the infection. So I will not go into that. We have seen it. It is most of the time present. Next is the hypercalciuria. This is something you have to take into consideration. Hypercalciuria. Whenever the amount of the calcium crystal is increasing, obviously their concentration in the urine is increasing, and if the concentration increases, then the chances of precipitation will help in formation of the stone formation. Now, when will you get hypercalciuria? The patient who are having a genetic defect, they will present with a hypercalciuria. Patient who are taking excess calcium in their diet may have a chances. Patient who are coming from the stone belt, rivers which are containing calcium carbonate or lime, like this our area, Praura water. The Praura river contains lots of calcium carbonates. So the amount of calcium may be higher. So that will increase. And one more thing you have to remember, that the parathyroid, which are responsible for the calcium metabolism, maybe are responsible for formation of the stone. So when patient comes with a hypercalciuria, don't forget to rule out hormonal problems related to the parathyroid gland. Similarly, if the person is gouty or having a hyperuremic condition. So this is related to what? Protein metabolism. And protein metabolism, that is producing the uric acid. So the patient who are having a increased uric acid level in their serum, that will reflect excess amount of the uric acid in or the uric acid crystals in their urine, and that will lead to the formation of the uric acid stones. So patient who are coming with a recurrent stone usually are gouty and may have a hyperuremic conditions. That you also have to remember. And first, as I said, primary stone which is made up of urate stone, and later if there is additional condition like infection or stasis, it will be a precursor for the secondary stone. Similarly, hyperoxaluria, all these are responsible for increasing the concentration of the solute part. That is, the crystal part is increasing and that may get deposited. Similarly, patients who are bedridden and paraplegic. You might have seen the patient who are bedridden for a long time have a osteoclastic activity. That means their bones, the calcium from their bones get mobilized very fast, and that may result into a formation of stone. In addition, this is a mechanical problem, bladder diverticulum. You can see this. This is a bladder diverticulum where additional diverticulum. Obviously, this part is out of this bladder. So the evacuation of this part is evacuation of the urine within this part is not possible. So this is a stagnant area where because of stagnation, chances of stone formation are very high. The neurological condition, whenever a person who is having a neurogenic bladder, that means he is not able to evacuate, so there is a continuous filled bladder because of the inability to evacuate the bladder. So neurogenic patient who come with a spinal injuries or after the paralysis, hemiplegia, these are the candidate, because they may have, till they are catheterized, they may have a overflow incontinence. What is overflow incontinence? That means the bladder is emptied only after completely filling. So there is a stagnated urine all the time, which is a good platform for the formation of urinary bladder stone. Then stasis or obstruction of the urine, which is very common, especially in the elderly children, elderly patients. There are multiple conditions like bladder neck obstruction, benign prostatic hyperplasia, or urethral stricture, which may happen in young patient also. One more thing, the foreign body that we have discussed in detail, and another parasitic condition that is called as a schistosomiosis, also called as a bilharziasis. It is very common in the country like Egypt, where the schistosomia parasites, their life cycle goes in the human body and they reach and finally find their destination in the bladder. In the bladder, you can find the physical presence of this parasite which get buried into the bladder mucosa. This parasite look like this, and actually with a magnified cystoscope you can make out the parasites which are causing this ulcer. Now this ulcer will cause squamous changes in the transitional epithelium, and it may further, if it is not treated, if it is not removed, then it will lead to ulceration. Then it will change the bladder mucosa from transitional to the squamous epithelium, and it may induce a malignancy. So these squamous cell malignancies are very common in a patient with a bilharziasis or the schistosomia. Let us see the clinical patient. How the patient usually presents. Common in males, urinary bladder stones are very common in males. You will hardly see any female patient coming with the condition of a urinary bladder stone. Why is it so? One of the reason is maybe because of the anatomical predisposition. If you have seen the anatomy, you will remember that the female urethra is straight, broad, and only 4 cm long, and it's wide. As compared to that, the male urethra is almost average 15 cm long, having many narrowings in between. So the passage of stone is difficult from the male urethra. So how this might be contributing to the formation of the stones. So in elderly patients, the conditions like BPH, bladder neck obstruction, these are not seen in female. So the patient who are having BPH as well as bladder neck obstruction or BOO are more candidates. That's why you see this formation of urinary bladder stone commonly in the male. Also it is common in the children. Maybe that is associated with the protein energy malnutrition. The complaints with which the patient comes who are having bladder stone, they give you a very typical history of a increased frequency of the urination during the day than the night. Why it is happening? Because of the standing, if there is a stone inside, that stone will come into the contact of the trigone. Let us see this diagram. This is the trigone and this is the stone. So when the person is standing, obviously this stone will gravitate and will come to this narrow part, and obviously that will come in contact with the trigone. Now this stone continuously irritates the trigone, and the trigone gets a signal as if it is filled, or that trigone gets irritated and evacuation reflex is initiated, and this keeps on happening. Also this patient will feel the pain while jumping or during the jerky traveling. Every time the stone will jump and it will again strike on the trigone, that will add to the pain in the bladder. It will also happen that this will gravitate down and it will close the outlet of the bladder, and that will result into the sudden urinary outflow obstruction. This patient may be able to pass after changing the position, but every time he passes the urine, still that stone remains in contact with the trigone, and this patient always complains of an incomplete evacuation in sense. Now typically this patient complains, or rather they say that they get relief during the night. Why this happens? Again, this is a simple mechanics. So this is a standing position where the stone will gravitate down and that will come at the outlet and it will obstruct. And similarly, when the patient lies down, the bladder will take this position, and what will happen to the stone? The stone will now gravitate towards the fundus or into the body of the bladder, and obviously this contact with the trigone is lost. Now this bladder can get filled nicely and the patient can have relief because of this simple mechanical fact. Now next important thing is that how to diagnose on the history. Every time a patient who is likely to have a urinary bladder stone will give you a typical history that you must keep your eyes, your ears trained. That is, patient will give a typical history of pain referring to the tip of the penis, or in females the pain referring to the labia. Once you listen to this kind of complaint, the first warning in your head should be about the possibility of bladder stone. Some of the patient may complain of suprapubic pain and tenderness, and as said, some of the patient who are having the stones which are having spikes or rough surfaces may cause irritation of the mucosa, and that will lead to hematuria. But this hematuria, again, this typically it's a terminal hematuria and usually happens with the oxalate stones. Patient may complain of a sudden interruption because the stone is small in size. Smaller the stone, the chances of obstructions are high, because every time it is gravitating down and it is obstructing the outlet. So slowly the patient learns to change the position. So I have seen patient who says that whenever they get obstruction of the urine, they lie down. One of them says he does the Shirsasana, and that helps him to again later pass the urine easily. The patients, as we say, are associated usually with a infection. So infection of a bladder, that is the cystitis. So patient may have The symptoms because of cystitis, they are burning micturition, increased frequency and pain during the passage of. So next comes how will you diagnose, or what are the things that will lead you to the considering the possibility of presence of the urinary bladder stone. First is that, as I said, you have to take the history very carefully. The history will suggest, or the complaints will tell you, that there is a history of a pain referring to the tip of penis or labia. So this is a patient to be diagnosed, to be investigated always for a urinary stones. It may happen that patient has come for something else. Patient comes for a pelvic pain, backache, then you send this patient for X-ray abdomen, X-ray spine or X-ray erect abdomen, and what you get is suddenly you notice a shadow which is in the region of pelvis. And if you examine this patient and if the stone is large, you can actually feel the stone via the pervaginal examination in female or the perrectal examination in cases of male. Nowadays nobody is doing this urethral sounding, but because you will come, somebody might ask you about the history. So how previously the people were diagnosing the urinary bladder stone? I have seen when I was doing my internship, we had a very senior pediatrician and he has showed us this method of a sounding. So you can diagnose a bladder stone by introducing an instrument that is called as a urethral bougie, or this is also called as a urethral sound. So this is made up of a steel and having a gentle curve, and this is a blunt end. This is hardly 3 to 4 millimeter thick, and you can have a measurement because there are measurement sites on this sound. Now we introduce this sound into the bladder, and then when it reaches the bladder, you just rotate it. So when you rotate it, it used to hit the stone and giving you a twang like sound. So that is why it is called as a sounding, because it literally gives a sound. So any probing is also, you are aware of the grammatically it is called as a sounding. So it gives a sound. But how you will diagnose, what are the investigation that you will carry out? The first and simplest investigation that you must do is the X-ray KUB. X-ray KUB, you are aware it's a kidney, ureter, bladder. Now as we have come to this topic of KUB, here I will advise to prepare a short note on the KUB. What is KUB? What are the boundaries? How you will identify the KUB? What are the preparations required? How do you read the KUB? And what are the differential diagnoses that you can find out by using the KUB? So this is an additional exercise for you. How does it look? I have taken only highlights. This is not exactly KUB. This is only pelvic portion, or this is showing a bladder region where you can see this opaque shadow. Now once you see this opaque shadow, you can think of a urinary bladder stone, also known as a vesical stone. Next investigation you can sometimes do is the X-ray pelvis. If you come across, so there is no, you are having a suspicious shadow and you want to see in details, in that case you can go for X-ray pelvis. But if you are doing a X-ray KUB, then there is no point in doing the X-ray pelvis. So this is a X-ray pelvis where you can see the opaque shadow in the region of bladder. Next investigation, that is gold standard, everybody is doing and you are aware, that is bladder ultrasound. If you are observing in ultrasound room, what you will see is that can you see this is a bladder which is full. This black shadow is of filled bladder, and here you can see the white shadow, and there is a acoustic shadow. You can say this is called as a hyperechoic shadow. This is very much suggestive of the urinary bladder stone, and this shadow is called as a hyperechoic shadow, which is associated or which is present along with this solid shadow. Next is you can look for a intravenous urography. Actually you never diagnose a bladder stone with a intravenous urography. Why? Because see, this is area here, you can see it's a bladder stone, but you cannot comment this as a bladder stone because here you can see the dye, and here is obviously there is a dye which is present in the bladder. So you cannot exactly tell that this is a bladder stone or this is a dye which is present. So for that purpose you will have to take a KUB, and on that KUB or this intravenous urography is always primarily accompanied. So it is preceded by a pilot photo, that is a KUB. On that if you can see the shadow, then you can always relate. Or sometimes it may happen that this bladder is filled with a dye and you can see a filling defect in the form of this stone, but you require expert. But usually you don't comment directly on the IVP about the, you can always say there is a radiopaque shadow that can be commented well only in the KUB but not on the IVP. So sometimes we will discuss about the IV also. Now how does it look on the CT scan? So CT scan, in this section you can see a radiopaque shadow in the region of the bladder. So you need a correlation of sections for diagnosing a CT scan, urinary bladder on the CT scan. So that is a imaging of the bladder stone. And last is you can always go for a cystoscopy. That will be a sure shot evidence by observing it directly. So through the cystoscope you can look for this. These are very large bladder stone, but sometimes there are small stones which can be seen and at the same time removed with the help of a cystoscope. So that is how you carry out the imaging of the urinary bladder stone. So there has to be additional investigation that will aid or that will help in your diagnosis. That is, as we said, all the urinary bladder stone are usually associated with the infection. Then for that purpose, every time you must go for a urine routine and microscopy. And if there is a suspicious of the infection, then you might go for the urine culture and sensitivity. Next is, because there is a presence of a infection, because there is a presence of a stone, and you are going to either deal this patient with the intervention. In that case, a basic primary renal function test must be established. So that will include blood urea level or blood urea nitrogen, serum creatinine. Then if the patient is coming with a recurrent stone, in that case it will be very helpful to carry out the serum calcium levels. If the patient gives a history of a bony pain, Tophi arthritis or gouty arthritis, in that case serum uric acid, and you can also go for a serum phosphatase. So this may not help you, but it is always a good decision to carry out these investigations even if the patient is coming for the first time. So if the patient comes later with a recurrence, then you always have a luxury of having a primary investigation by doing this serum calcium, serum uric acid and serum phosphate. And obviously if you are planning for if there are urolithiasis, patient is having a bladder stone as well as ureteric stone and you are suspecting obstruction, in that case if you decide to go for a IVP, in that case RFT is also required. So you cannot go for a IVP without having a clearance of the serum creatinine. Now, what are the possibilities? Every time you see a radiopaque shadow in the region of bladder, do you think it is always a bladder calculus? Let us see. What is this? If you describe this X-ray, this is sort of a X-ray pelvis. In the bladder region, I can see a rounded opaque shadow. The first differential diagnosis is yes, urinary bladder stone. But is there any other possibility? Yes, read this. So what is this? Actually this is a calcified uterine fibroid. So don't forget, there are certain diagnoses which will give you a radiopaque shadow in the region of pelvis or in the region of bladder. So one is dermoid cyst. Dermoid cyst, you are aware of it. The content of the dermoid may be from all the germinal layers. So sometimes it is containing the tooth or it is calcified. In that case, you will have a calcified. So actually that is present either in the ovary, and what you see this as a bladder stone or in the bladder region. So that is, remember, you have to rule out this. Another possibility shown here is the calcified fibroid uterus. Next possibility, that every time or everything that seems in the bladder region may not be bladder stone, but it could be a large ureteric stone also, which can be misinterpreted as a bladder stone. Now let us see this. Prima facie, what is this? Looks like a bladder stone because this is in the bladder region. Straightforward, in the middle almost. But once it is investigated, now see the IVU. What is this? This is the lower ureter and this is present at the UV junction. So this is a ureteric stone, not a bladder stone. So that diagnosis you also have to remember. So let us come to the final part of this lecture. What is the treatment? Yes, most of the patients who are presenting will undergo surgery because there is no choice. Surgery, that means it could be a invasive or non-invasive. Invasive means cutting for the stone or going with the cystoscope. But what is the indication for the surgery? That includes recurrent urinary tract infection, acute urinary retention and a frank hematuria. Rather, I will say this is the old style. Every patient who is having a bladder stone will require a surgery. But remember that there is no point in removing only the bladder stone. You also have to treat the cause which is leading to the formation of bladder stone. For example, patient who comes with a BPH and having a obstructed uropathy or having a obstructed, there is a urethral obstruction because of the prostate. Now you remove the stone. Afterward, patient will again come back. So what is essential? You have to remove the stone. At the same time, you will have to deal with the cause. So if there is an obstruction, that you will have to remove also. That's why it is said that any underlying bladder abnormality must be dealt or must be sought, that is leading to the formation of stone. And yes, as I said, all of them will require surgery at some time. Available methods. Before going into the surgery or cutting, you will wonder that why not go for this extracorporeal shock wave lithotripsy. You are aware, ESWL or lithotripsy. That means banging the stone with the ultrasound waves, and because the stone is formed by particles, it will disintegrate, right? But that is possible in the kidney where the stone has got a support that is held within the walls of the kidney, or ureteric stone which is held within the walls of the ureter. Here what will happen, if you focus the ultrasound on the bladder stone, because the space is so big, so because of that impact the stone will get dislodged and it cannot be held at one point. That's why the extracorporeal shock wave lithotripsy will not work in the cases of bladder stone. So what remains? There are three options remaining. The first option is the open suprapubic cystostomy, that is available everywhere, or you can go via the cystoscopic mechanical lithotripsy, that means introducing a cystoscope, and then through that cystoscope you can break the stones, disintegrate, and then the smaller pieces are removed through the cystoscope. And third, which is not nowadays used commonly, is the percutaneous cystolitholapaxy. That means opening the bladder with a small incision from suprapubic approach, making a rent, and through that rent you deal with the bladder stone. So let us deal one by one. First, talk about the open suprapubic cystostomy, or rather it is called as the heading is wrong. You read it as a open suprapubic cystolithotomy. Make sure, cystolithotomy. This is done through the suprapubic approach. You can take two type of incision. Either you can take a lower midline infraumbilical incision from the umbilicus to the pubic symphysis vertically. Then you split the rectus, then rectus muscles are split. What you see now is the peritoneum. Don't open the peritoneum because the bladder is retroperitoneal. So whatever the peritoneum which is seen is now reflected upward. So once that is reflected upward, you will see the straight muscles of the bladder. And how it is usually open? You keep the bladder filled so that you can easily localize the bladder. Then once you see the bladder, introduce a needle and confirm that this is a bladder. Then take an incision that is called as a suprapubic cystolithotomy. So once you take an incision, broaden it, introduce a bladder catching forceps, and like it is shown in the figure, remove the stone through this suprapubic cystolithotomy. Introduce your finger, make sure that there is no other stone, give a good wash so that the debris inside must be removed, and then nicely you repair the incision which is taken over the bladder in 2 layers. Again, make sure that your sutures will remain outside and you will use absorbable material. You will never use non-absorbable material, right? So previously we were using catgut, chromic catgut, and nowadays we are using Vicryl, so that it's a delayed absorbable, but the knots must come outside. Then you close it in the 2 layers, keep a drain, make sure that your sutures are watertight, and then you close it. Next option is, so what can they, because this is open surgery, there are certain complications which are associated with open surgery. What are the possibility? One is opening of peritoneum, so that you will have a opening of peritoneal cavity. You can introduce infection because afterward you are going to open the bladder, and we are saying that most of the bladder stones are associated with infection, so that infected urine can enter into the bladder. Then injury to other organ. While you are opening, you may cause damage to the surrounding organ. Peritoneal contamination like I described. Then you are aware that bladder is having abundant blood supply. So if you don't close it properly, then there could be a hemorrhage. Sometimes if you don't take careful suturing, if you don't do the watertight suturing, in that case there could be a urinary leakage. And very rarely, this usually will not happen, but if there is a communication, then there might be a formation of a urinary fistula. Now next is the cystoscopic mechanical lithotripsy. That means introducing a cystoscope. Then there are 2-3 methods. One is if the stone is small, say 1 centimeter, then you can insert this mechanical lithotripter, which is having a sort of a crocodile jaw. So it is simply you hold it, crush it, and then give a wash, so everything will come out. So a small stone of say size 1.5 centimeter can be easily crushed with this. Otherwise, you can go for a mechanical lithotripter. Now you see, here is a jaw. This is expanded here, and this is having to and fro action. With this, you can almost crush stones of a size say 2 centimeter, 3 centimeter, 4 centimeter. And with the experience, you can go for almost up to 5 centimeter also. So how it is done? So this is actually pushed to the wall and then got the hold. And between this jaw it is held here. And now this will be pushed up so that it will break it. Once it is broken, then you will get at different edges. Then it becomes easier to catch this. And slowly you go on disintegrating the stone and the pieces are removed. Third is the percutaneous litholapaxy. I will not describe this because this is through the small incision you will enter into the bladder, and directly like this you will crush the stone and take the pieces out. Why you are using this? Because it is difficult to deal with a very large stone, because you will be coming through the urethra and you can insert very small instrument that cannot break the large stone. So instead of that, you enter from here with a very small approach, or at the same time you can introduce a cystoscope, observe it, and from here you introduce the instrument by which you can directly crush them mechanically. So this is a percutaneous cystolitholapaxy bladder stone. So what is the treatment available? Here you can directly go for a open surgery, that is suprapubic cystolithotomy, or you can go endoscopic mechanical lithotripsy, and third is percutaneous cystolitholapaxy. Right? This is just additional exercise. This is a degestant. This is a forgotten degestant. What has happened? There is a stone here and there is a stone in the kidney. This is another where you can see there is a stone. Now here, because this stone is not in the dependent position, you will have to find out whether this is a ureteric stone or a bladder stone. This is recently removed. You can see, if you remember your first slide, or when you close this, just see the first slide. These are the stones which are removed here only, and these is also stones which are removed just last 2 months. And you can feel, just for comparison, this hand is kept here. So there are, and this patient in addition had a BPH. So 2 operations were done. So through the suprapubic cystolithotomy, these stones were removed, and at the same time his prostate was, URP was also done. This information, this is just a highlight information. You can go, and if you are interested, you can go and read the Smith's Urology, that has given a nice account of this. Thank you.